Hello friends, greetings from RFATUTORS, your mentor at the side with the green top guideline of the day. Today we are here to tell you about the operative vaginal delivery, the green top guideline number 26, published in April 2020. Operative vaginal delivery rates have remained stable at between 10% and 13% in UK, yielding safe and satisfactory outcomes for the majority of the mothers and the babies. There has been a rise in the rate of cesarean births in the second stage of labor. This may reflect concerns about assisted vaginal birth morbidity or loss of the clinical skills. The classification of assisted vaginal birth, the outlet, the load, the mid-cavity are very important for exams. I will explain in details the station and what instrument you have to use. To encourage the women to have continuous support during labor, as this can reduce the need for assisted vaginal birth. Inform women that epidural analgesia may increase the need for the assisted vaginal birth, although this is less likely with newer anesthetic techniques. Encourage the women not using epidural analgesia to adopt upright or lateral positions in the second stage of labor, as this reduces the need for the assisted vaginal birth. Encourage women using epidural analgesia to adopt lying down lateral positions rather than upright positions in the second stage of labor, as this increases the rate of success. Recommend delay pushing for 1 to 2 hours in nulliparous women with epidural analgesia, as this may reduce the need for rotational and mid-pelvic assisted vaginal birth. Do not routinely discontinue the epidural analgesia during pushing, as this increases the women's pain with no evidence of reduction in the assisted vaginal birth. This is the recommendation year 2020. There is insufficient evidence to recommend any particular regional analgesia technique in terms of reducing the incidence of assisted vaginal birth. There is insufficient evidence to recommend routine oxytocin augmentation for women with epidural analgesia as a strategy to reduce the incidence of assisted vaginal birth. There is insufficient evidence to recommend the routine prophylactic manual rotation of fetal malposition in the second stage of labor to reduce the risk of assisted vaginal birth. Operators should be aware that no indication is absolute and that clinical judgment is required in all situations. Suspected fetal bleeding disorders or a predisposition to fracture and relative contraindications to assisted vaginal birth. Blood-borne viral infections in the women are not an absolute contraindication to assisted vaginal birth. The use of vacuum is not contraindicated following a fetal blood sampling procedure or application of a fetal scalp electrode. The operator should be aware that there is a higher risk of subgaleal hemorrhage and scalp trauma with vacuum extraction compared with forceps at a preterm gestational age. Vacuum's birth should be avoided below 32 weeks of gestation and should be used with caution between 32 and 36 weeks of gestation. The indications for assisted vaginal birth, the fetal, the maternal, and the combined. Important single breast answer. The safety criteria for assisted vaginal birth, the full abdominal and the vaginal examination, it's very important as prerequisite of the assisted vaginal birth. Continuation of the safety criteria, the table 3 of the Green Top Guideline. The ultrasound assessment of the fetal head position prior to assisted vaginal birth is recommended where uncertainty exists following the clinical examination. Women should be informed about assisted vaginal birth in the antenatal period, especially during the first pregnancy. If they indicate specific restrictions or preferences, then this should be explored with an experienced obstetrician, ideally in advance of the labor. When mid-pelvic or rotational birth is indicated, the risk and the benefits of assisted vaginal birth should be compared with the risk and benefits of the second stage cesarean section. The assisted vaginal birth should be performed by the presence of or in the presence of an operator who has the knowledge, skills, and experience. Ensure that obstetric trainees receive appropriate training in vacuum and forceps, and complex assisted vaginal birth should only be performed by experienced operators. An experienced operator competent in mid-pelvic birth should be present to supervise all attempts at rotational, mid-pelvic, and assisted vaginal birth. The operator should choose the instrument most appropriate to the clinical circumstances and their level of skill. This is what I would guide you in all the scenarios. The vacuum extraction as compared with the forceps in terms of their complications. The operator should be aware that soft cup vacuum extractors have a higher rate of failure but a lower incidence of neonatal scalp trauma. The rotational births should be performed by experienced operators, the choice of the instrument depending on the clinical circumstances and expertise of the individual. Discontinue the vacuum-assisted birth when there is no evidence of progressive descent with moderate traction during each pull of a correctly applied instrument by an experienced operator. Complete the vacuum-assisted birth in the majority of the cases with a maximum of 3 pulls to bring the fetal head on the perineum. 3 additional gentle pulls can be used to ease the head out of the perineum. If there is minimal descent with the first 2 pulls of the vacuum, with these pulls, the operator should consider whether the application is suboptimal, the fetal position has been incorrectly diagnosed, or there is a cephalopelvic disproportion. Discontinue the vacuum-assisted birth if there have been 2 pop-offs of the instrument, and less experienced operators should take senior support after 1 pop-off to ensure that women has the best chance of a successful assisted vaginal birth. The use of the sequential instrument is associated with an increased risk of trauma to the infant. Obstetricians should be aware of the increased risk of obstetric anal sphincter injury following sequential use of the instrument. Discontinue the rotational forceps birth if rotation is not easily achieved with gentle pressure, and discontinue attempted forceps birth if the birth is not imminent following 3 pulls of a correctly applied instrument by an experienced operator. If there is minimal descent with the first 1 or 2 pulls of the forceps, the operator should consider whether the application is suboptimal, the position has been incorrectly diagnosed, or there is a cephalopelvic disproportion. Obstetricians should be aware of the potential neonatal morbidity following a failed attempt at forceps birth and should inform the neonatologist when this occurs. The medial lateral episiotomy should be discussed with the women as part of the preparation of the assisted vaginal birth, friends, and it has to be given at 60-degree angle as per the college recommendations. In the absence of robust evidence to support either routine or restrictive use of episiotomy at assisted vaginal birth, the decision should be tailored to the circumstances and preferences of the women. A single prophylactic dose of intravenous amoxicillin and clavulanic acid should be recommended following assisted vaginal birth as it decreases significantly confirmed and suspected maternal infection. In the absence of contraindications, women should be offered regular non-steroidal anti-inflammatory drugs. Women should be educated about the risk of the urinary retention so that they're aware of the importance of bladder emptying in the postpartum period. A shared decision-making, a good communication, and the positive continuous support during labor and birth have the potential to reduce the psychological morbidity following the instrumental birth. Offer advice and support. Do not offer single session. Offer women with persistent post-traumatic stress disorder symptoms at 1 month referral to skilled professional as per NICE guideline. Inform women that there's a high probability of a spontaneous vaginal birth in the subsequent labors. The paired cord blood sample should be processed and recorded following all attempts of the assisted vaginal birth. The documentation is essential. The obstetrician should ensure that the ongoing care of the women, baby, and the family is of paramount importance. The obstetricians have a duty of candor, a professional responsibility to be honest with patients when things they go wrong. The safety criteria of operative vaginal birth, a very important algorithm for single best answers and extended match question. Also, for record, it has been revised. Some important exam points from this Green Top guideline are the operative vaginal delivery indications, when to choose which instrument. I will guide you in detail on this in the live session, and the contraindications of the use. Best of luck from the entire team of RFA tutors. I thank you all for being with us today. Until we meet again, take very good care of yourself. Bye-bye.